everyone, and welcome to Under the Microphone, the podcast where we dive into the fascinating world of science and the people who make it happen. My name is Antoinette. I'm a scientific consultant and founder of Relab, and also your host for Under the Microphone. We are very honored to invite our first guest here today, one who inspired me personally, and is, of course, also the inspiration behind this podcast. Thank you so much for joining us today, Mr. Warren Maule. We are so excited to have you here and to learn more about you and your field of study.
I want to thank you for giving me this opportunity to do this. This is something new for me. I'm a real technophobe, so when it comes to computers, I don't really have too much skill. But anyway, let me introduce myself. My name is Warren Maule. I'm a retired biomedical scientist. I've been retired since 2016, initially from UJ, where I had my last appointment. I mean, I started in laboratory work in 1966, would you believe?
How?
So next year I've been in the field for, my goodness, this sounds terrible now, 60 years. In the field of really a beginning of medical technology and then biomedical science. So I started in hematology. It was quite a small laboratory in the Royal Infirmary in Edinburgh. That time we had very little in the lab. You know, we had no instrumentation, we had no diagnostic or diagnostic companies, we had no controls, we had no real standardization. We had very little.
How has the field changed over the years since you started?
It has changed dramatically. I mean, I can't really explain it. I mean, in the last 10 years even, hematology has gone from really looking at cellular aspects of the work to looking at what's inside the cell. I can give an example. Here in South Africa, it's mainly used in the field looking at HIV patients. In other words, patients that have this preponderancy to develop AIDS. And we have these two cells. We have CD4, which is really a helper cell, and we have a CD8.
Is the CD4 cell like a white blood cell?
It is. It's part of our immune system. It is part of our lymphoid system, our lymphocytes. It's a helper cell that helps us produce these B cells to fight off this infection. And we have different types of B cell, everything from the pre-B cell to the mature B cell that produces these immunoglobulins, they're called. We don't have it, or we have very little numbers, and the numbers are, given in around about 200 is the baseline, and even that is low. Now, the problem is that the HIV virus targets the helper cell. It targets the CD4 cell and gets rid of it. So, in fact, these patients become susceptible to all types of infection, opportunistic infections, everything from problems with the mouth to problems with their organs, basically, and the development of eventually AIDS. Now, today, of course, in South Africa, the introduction of antiretroviral drugs and HART, and really looking after these patients from the point of view of taking medication, has really prevented these patients developing AIDS. Their CD4 count doesn't go below 200, and the viral loads that these patients have is also kept at bay. And we've got analyzers that can look at viral loads through PCR. The only instrumentation we had was basically the microscope, centrifuges, and spectrophotometer. That was it.
Wow.
That was it. And, I can tell a funny story. I mean, there's a test called the ESR, which is still used today. It's the erythrocyte sedimentation rate. They still use these pipettes, but they use them in analyzers today, and it's plastic. But in the time in 1966, we didn't have plastics. So we used glass. Now, the austerity measures in the lab, to save money, we reused these pipettes. So we had a wash-up area in the lab that employed people actually to do all the washing up. But also these pipettes could get broken, especially the first part of the pipette. In other words, pipette to zero. So these pipettes went from 0 to 200 millimeters, and they still do today. But if this part broke, then we had these glass cutters and little sandpit, but they ended up, the space between the top of the pipette and 0 was like this.
Oof.
So you had to sort of, and of course your propensity to get blood into you and sometimes swallow it.
Oh no.
Yeah.
Isn't that dangerous?
extremely dangerous. I can talk a little bit about it because we had no safety standards. There was no gloves. There was no standard of safety. This all changed really in the 1970s because what happened was there was an outbreak of hepatitis in the Western General Hospital in Edinburgh. And unfortunately, this outbreak, 4 people succumbed. And one of them was a medical technologist. And the other one was a young girl that worked in the sample or receiving samples, reception basically. And they accidentally fingers stuck themselves with infected samples. Now in the 1970s, this all changed from a gentleman called Howie. You can read this report if you want at your leisure. It's called the Howie Report of Safety and Standards. And it's a huge report, but the standards changed overnight, basically. Mm. The movement away from mouth pipetting to actually using plastics instead of glass, to actually using equipment that you didn't have to pipette anything at all. And I mean, I could go on about this all day. The changes in hematology from the 60s to now is just incredible, both technologically and scientifically. And, you know, in biomedical science, the fields have even changed. I'm talking about the fields of study now.
You've mentioned biomedical science a few times. Could you perhaps give us some insight to what biomedical science, what the term means?
It's really in the wording. If you look at biomedical, because in the old days it was medical technology, but now it's biomedical. So basically, in simple terms, biomedical science is really medical, but it's looking at people really and diagnostic work. In other words, using different techniques to come up with an answer. So it's really around medicine, really, and really helping patients.
So basically, medical scientists, they produce the results that doctors use, right?
Yes, but we're really unseen heroes. We're not seen by the patient. But I have to say, and this is very important to me, that any sample that comes into the lab comes from someone. And we as biomedical scientists have to treat that sample with care, ethically, and to actually give the best we can. In other words, to test this properly, using the proper standards, the proper quality in the lab to produce the best results, to give the clinician the results that are meaningful. In other words, without biomedical science, doctors, clinicians, pathologists would not be able to diagnose what is wrong with patients today. So it's really an unseen, or the biomedical scientist is an unseen hero, perhaps, you know, because they are not seen. A doctor is seen. If you go to visit a doctor or a pathologist, they are personal. They're there with you. But it doesn't mean to say that the biomedical scientist isn't personal, because they deal with all sorts of samples which come from people. Mm-hmm. And so it's a people-orientated profession, really. The main disciplines in biomedical science today, the first one is, well, it used to be called clinical chemistry, but it's now given a different title. It's called pathological chemistry, but it's really looking at your organs and what happens. If you look at the liver, for example, we can do various tests to look at the function of your liver, everything from liver enzymes to other things. So it's looking at enzymes and the way the body works. The other one is microbiology, and that's self-explanatory. It's really looking at things that can do you harm, everything from bacteria to viruses to fungi.
Parasites.
Parasites, yes. The other one is my discipline is hematology, and it's sometimes linked with transfusion science, but now the disciplines are separate. But hematology is basically looking at the cellular elements of the blood. In other words, looking at the red cell, the white cell, platelets, other cells. And transfusion science is self-explanatory. It's to do with transfusing blood to patients safely. The other discipline is histopathology, and it encompasses cytology. When we look at histopathology, it's basically around biopsy and autopsy work. But if you look at cytology, it's looking at the cellular elements, mainly around HPV and the preponderance to cervical cancer, ovarian cancer, etc. They're really the main disciplines, but we have offshoots of that now. We have immunology, which is linked to hematology. We have genomics, which is really looking at how cancer works and we have cancer markers in patients. We have cytogenetics, which is looking at within the cell, the chromosomes, the chromosomal abnormalities, and there are many of them.
So what do you specifically focus on?
Morphology. It's something very close to my heart, and of course that's changing. And we can talk about this later perhaps as well. Because of artificial intelligence and because of machine learning, we can use that to really do cell division. In other words, look at the cells using AI. And it groups the cells and gives the morphologist an idea of abnormalities, perhaps.
Are you talking about, for example, like sickle cell anemia? You were specifically referring to blood cells, correct?
Yes. Now sickle cell is slightly different. We don't have, to my knowledge, artificial intelligences yet that can tell us a patient has got sickle cell anemia, because it's quite complicated. Because, again, it's a problem with the hemoglobin molecule. And the hemoglobin molecule is extremely complex. A guy called Max Perutz, he used X-ray crystallography to analyze this molecule. And it's a 3-dimensional molecule. So not only does it carry hemoglobin, but it's also involved in iron as well. So sickle cell anemia is around that molecule. It's mainly with the beta chain. Our hemoglobins are made up of, basically in adult, 3 types only. That's all you have to remember. Hemoglobin A, hemoglobin F, which we have many minute parts of it, and hemoglobin A2. These are 3 hemoglobins, but the main one is hemoglobin A, and it's made up of alpha 2 and beta 2 chains. So sickle cell is to do with the beta chain. It's in position 6, and there's a change in protein. Change of glutamic acid for lysine. And that's what produces this rigid cell, because normally the red cell is very deformable. It can go from your capillaries to your heart without destruction, but the sickle cell, no. Because it's very rigid, it causes big problems in these patients.
It can cause blockages, correct? Like clots and stuff, because they can attach to each other.
What happens is they pile up on one another. So it causes blockages. They have crises, these patients, visceral and vascular crises, would you believe? So it causes extreme pain. But not only that, it causes problems with your lungs and the hemolysis. So we've got an amazing array of treatments now, which we didn't have. Well, basically, we had no treatment. That's only very bad now. But in the 60s, we had very little treatment. We had very little morphological knowledge of the cells. That's why it's big in my heart. And you must remember the microscopes in the 60s are not what they're like today.
Of course.
Then we can see these cells under the microscope. We can see the sickle cell. The hemoglobins are big for me because of the fact that we have different types. And this type of disorder, well, it's close to my heart again, because I spent 10 years teaching in the Sultanate of Oman, which is in the Middle East. And they have many, many hereditary problems there. But one of them is sickle cell, but they also have their own hemoglobin. Now, I'm giving you homework. I'm giving you homework to do now. You can actually look it up.
Okay.
HB Oman, all right? And it's a type of sickle cell anemia, but it produces different types of cells to the normal sickle cell. They're sort of very strange shapes, all right? But I'm giving you homework. You can look this up yourself. It's quite interesting. So we have all these means of diagnosing many things today where we didn't have in the past. Now, I can tell you, to diagnose leukemia in the 60s, we did have bone marrow aspiration, but we had very little techniques. The advancements in technology is incredible, but the science of diagnostic biomedical science is incredible.
No, it must have been amazing to experience all that and to see all that through your lifetime.
I mean, I spoke to you about it. I maybe should think about writing a history book about it.
I think it's also important to write down how it used to be done, because I feel that with a lot of technology and advancements in technology, people use these instruments in the lab, but they don't actually know what's happening inside the instrument. And now the instrument doesn't work and they don't know how to do the test anymore.
This is one of the drawbacks of artificial intelligence, really, in my book. It's one of the drawbacks because we've still got the human element, but it doesn't mean to say that you forget about how it works, basically, because we need to know how it works because of the fact, and this is also big for me, is interpreted data, really. The AI will do this, but the human at the moment has to know this interpreted data. In other words, what the analyzer is giving you.
Yeah. No, I agree, because the people who are working, like you said earlier, the people who are working, especially in biomedical scientists, with the samples, they need to provide a result. If they don't treat that sample with respect and with with proper knowledge, they can cause an incorrect diagnosis and potentially change someone's life.
And it happens, absolutely. It happens. Thankfully, it doesn't happen that often. I mean, equality is also an issue. We should really prevent mistakes, not correct them. We've got all these ISO standards in place. We've got accreditation. We've got, all these things in place to prevent disasters happening. It doesn't mean to say that disasters don't happen. You have to do the best you can with all your knowledge, with all the things you have in place, all the results, all the things that you're getting. You have to make the best decision for that patient. And sometimes it can be hard. Sometimes it can be hard. The changes are still happening. Artificial intelligence, whether we like it or not, is going to happen. AI is able to diagnose or able to look at MRIs, CAT scans, the X-rays, much better than a radiographer can, because it's got access to all this information. I'm not saying it's good, but
Yeah.
at the end of the day, the radiographer still has to make a decision. We still need the human element.
Yeah, I think it's fantastic that we've got the opportunity now, from how you say you started in the lab, how we evolved, and we can better treat people, we can better diagnose people, but it also means that the skills behind that, the doctors and the biotechnologists and biomedical scientists, are losing their edge because they're becoming so reliant.
Biomedical science is not just about theory. It's not just about learning all these terms and how things work theoretically, but it's actually doing the practical application work.
Yeah, you have to have the knowledge and the background and the know-how and understanding what you do.
When I started writing, and I did write in the 60s, I wrote some work on platelets because it was a cell that we didn't really know much about. But you must remember, at that time we had no computers. We had no internet. We had no cell phone. We had nothing. So to get an article, you had to go to the library. You had to go to the medical library. You had to look for it. If they didn't have it, you had to order it. And it could take 2 weeks for it to come. And then you had to go through it like a fine-tooth comb, and then you had to write yourself this. There was no AI, nothing to help, no publications on the internet. Nothing. It was all hard copy. You could even get, ready for this, at the medical library in Edinburgh, you can get the original paper by Jenner on smallpox. Would you believe it? Would you believe it?
Wow.
Yes, exactly. So, things have progressed enormously. And again, some of it's good. Don't get me wrong. Some of it is really, really superb. But some of it is not. And we have to try and filter out the things that are not. And really, to try and train students today is becoming more difficult.
Seeing a lot of students and young people using AI to write their articles or to do their work for them. And now it's, you're losing that critical thinking, that ability to think for yourself.
I've finished this article now, and I kind of was influenced a little bit by this technology, or we call it technology. I still did most of the work myself. I had to review the papers myself. I didn't use AI to do that. I got hard copies because that's what I like. So I've still got them. I shouldn't show you them, but here's some of them. I still use that.
That's fantastic.
And people don't know what this is anymore. I'm going to just briefly tell you. We had to count red cells, white cells, and platelets manually. Now, the white cells and the platelets, not too bad. But red cells, horrific, because we've got a lot of them in our peripheral blood.
So what, do you take a picture and then count the picture?
No, you have to make a dilution of the blood.
Okay.
In a specific solution. I won't bore you. It's called Daisy solution. all right? And I could talk about DACI all day, but it's called DACI solution. So it's a red cell, it's a solution, but you have to dilute the blood in a dilution. I can't remember what the dilution is. It's maybe 1 in 200. I can't remember. And then, or it might be more. And then you have to put it on a thing called a Neubauer counting chamber, which is a special chamber that's lined with special lines.
Like a ruler on it?
Yes, but it's got a cover slip, which across it, but it's got a space where you...
Like a grid?
Yes, where you put a capillary of this dilution and it puts it in by, Brownian movement, puts it in automatically. And then you have to look under the microscope to count the cells. So you have to count the cells in the special grid, and then you have to do a calculation to calculate how many red cells there are. And then you have to do the same with the white cell.
That's fantastic.
Can you imagine giving this to a student today? I'm not criticizing. I think, that we need to teach this in a way that people are benefiting. I'm talking about the students now, this competency level, because you have to be competent, really, because you can be in the lab alone, even though you've got sophisticated analyzers. You still have to make a decision.
So since you don't have a research facility at UJ, what do you do that side?
As you've seen, with the articles that I sent you, it's basically reviews.
Okay. So you do mostly literature reviews?
Yes, around things that interest me. The lupus interests me because my wife has it. My wife has got SLE. She's had it since the birth of our son, and my son is approaching 50. But it's a disorder that is really quite complicated.
Could you maybe just briefly explain a little bit more on exactly what lupus is and what causes it?
It's a chronic autoimmune disease. These patients produce antibodies basically to everything from the cells to the organs. So it's an organ targeting disease, all right? The main organs are the kidneys, the targets. The other ones are the blood. The other one is, and I'm just briefly giving you an overview, the other one's the skin. The other one is the joints and the muscles. The other ones are the lungs. And the one that affected my wife is your brain, neurological problems with lupus. So it can be quite a drastic disorder.
What causes it?
That's the problem. Up until a recent article, which was featured in The Guardian of all things, they really didn't know. They thought it was genetic. They thought it could have been something that happened during hormonal changes in women, because it mainly affects women. But up until recently, they were unsure what caused it. But now there's a recent article, you can go read this, about EBV, Epstein-Barr virus, which is a common virus. We're all exposed to it on daily, basically. It can cause throat infection. The main one is a disease called infectious mononucleosis. Big words, but it's basically glandular fever. Maybe you've heard of it. And many people have it, but don't realize they've got it. They have it and just like a common cold. So they implicated this virus causing lupus. Now, it's been implicated in many other disorders, everything from certain leukemias to multiple myeloma, which is a disease of the plasma cell, basically.
And how is this diagnosed?
They've got 11 different criteria, and you've got to have 4 of these criteria to diagnose it. So it's difficult to diagnose, but one of the main criteria is positive double-stranded DNA antibodies.
When you say double-stranded DNA antibodies, does that mean the antibodies attach to double-stranded DNA and then the body attacks DNA?
Exactly. So it's very bad. But there are other means of diagnosing it through immunological markers, these CD markers, using flow. So you can use all that to diagnose it. The diagnostic part of it is not difficult today, but it's the treatment that's a problem, because each patient is different. They maybe believe that they can produce a vaccine against the EBV virus, so they can prevent this occurring.
Okay.
Well, preventative medicine is better than treating patient after they've got the disorder, if you get my drift.
Yes.
Preventative skills are better.
I would like to ask you a little bit about the tapeworms.
Yeah.
On your article, you mentioned that people can have these worms or these eggs, and they don't even have symptoms. So you could have eggs in your brain without even knowing.
Yeah, that's the problem with it. It's very rare, I may say, because normally you do have symptoms, but it depends where that lesion is. Generally speaking, what happens is, it is the tapeworm, this Tinea solidum eggs of the tapeworm. But what happens is these eggs are laid and they can lodge in your intestine. And then what happens is they migrate, and then they can migrate to your head. And then they form this lesion. And what happens is your brain tissue kills the egg, but you're left with this lesion in your head.
A calcified lesion, yeah.
I saw in that CT scan of this friend of mine. He's got this, which is there forever. You can't get rid of it unless you excise it. And it's sometimes dangerous to do that. That it's common in sub-Saharan Africa, this tapeworm. I don't think in hygienic circumstances you're going to get this. It's really people that are farming pigs unhygienically, that are not doing the proper things, that you've got a chance of getting this. It doesn't mean to say you won't get it, I may say. Because tapeworm, you can get it, but it's rare. That's what I'm saying.
Is there anything that you can take to prevent it?
You can, but it's not meaning to say, because these hemolytic worms, the treatment is different. Because tapeworm is a horrible thing. So you've got to take specific treatment for it. But it will get rid of it. But then I'm sounding very bad now, but you excrete it, can grow up to meters and meters and meters long, because they are in your small intestine,
And how would you know you have one? Do you have any symptoms?
You lose weight, because basically it has, well, you can read about that as well, because people auto-infect themselves sometimes to lose weight, which is not the best way to lose weight. But you lose weight and you have other symptoms because it makes you feel ill a little bit. But it's not a pleasant thing because it takes all the nutrients from your food.
But naturally, also, if you are infected with a tapeworm, wouldn't that make you also more susceptible to ingesting the eggs?
Obviously, you're susceptible, but generally the treatment gets rid of it. They give this this anti-worm treatment for this disorder, and you secrete this worm. I've seen them on display microscopes, these worms, right? On a display are you ready for that? I'm going to maybe gross you out even more, but you have to put it on a slide, right? The whole thing, and you're looking at its head, basically, because you've got to get the head of this thing. It can be that high.
Oh.
Round, yeah. So it gives you an idea of the length of it. Pretty horrific. Parasites, no, not my forte.
There's one other topic that I quickly want to just got over with you about, and that is about your article regarding cannabis or the use of marijuana.
Yeah.
So you mentioned there's some medical benefits.
Mainly for pain, basically. Patients that have malignancy, perhaps, and they have problems with chemo. So they have problems with vomiting and all sorts of things. And it does ameliorate that, believe it not. It's become very big. You can't go into a shopping centre now without coming across a cannabis shop selling
CBD
cannabinoid products. You can use the cannabinoid products, not the cannabis itself, because you don't want to use the THC part, which is the part that makes you high, all right? Or some people will say, yes, I'd rather have the high part, but you've got to use the other cannabinoids. There's many of them.
Using the drug recreationally among young people, what are the medical risks and potential benefits of it?
People smoke it. Smoking is not good because it can cause problems with your lungs. Other problem you have is you've got these receptors in your brain. A long-term use of cannabis is not good, really, or marijuana, should I say. It's not because THC does affect you. Well, these are extreme circumstances, but it can affect your brain, and you can have learning problems and all sorts. But the main one is schizophrenia. You can end up with schizophrenia, which is not a good thing to end up with. So you're going to be very careful in the use of it. That's why they regulated it. You're only allowed to grow so many plants. You have to have the medical profession trained in it. In other words, they have to know exactly how they're going to prescribe this because of the fact that, the regulations, you have to be sure that you're not going to do harm.
Mm. And there's not a lot of clinical research done on it, correct?
No, not yet. There are some, mainly around multiple sclerosis, because your quality of life is the problem, isn't it? So if you can ameliorate the dangers with quality of life, then that's okay, in my opinion. But it's not to say that I'm in favor of using it.
Recreationally, yeah.
It's got many side effects, and especially, smoking it is not good. I mean, I was talking about using cannabinoid products like diffusers and things and liquids, because you can't smoke it because it does you damage. It's got lots of good things, don't get me wrong, because these shops would not exist, because you can use it as creams, joint problems. It does get rid of pain. There's no question about it. And you can't get hooked on it. You will not get hooked on these cannabinoid products. They're just purely like you would buy a cream in discount for your face or whatever, makeup or whatever. So you won't get addicted to these products, but they've got to be regulated, and that's what they're trying to do. SAHPRA are trying to do that now. They're trying to make sure that these products are controlled quality-wise, and that the standards are correct. That's what I'm saying.
Do you perhaps have any career highlights that you would like to share with us?
Many. I think, for me, the biggest highlight was coming to South Africa, believe it not. Coming here was a big strain on our family because our children were small.
You're from Scotland, right?
Yes, 1982. My daughter was 7 and my son was 5. I don't regret any of it. It was an amazing time because what happened to me was I got the lab manager position in hematology at Baragwanath Hospital, and I was involved because I was involved in computerization of laboratories in Scotland, moving away from paper to paperless to digital, basically, of using computer technology, and I was involved in computerizing the lab there as well. And really working for the South African Institute for Medical Research, I learned so much. And we had clinics there as well. So we saw the patient. I got to meet so many different people. I got to know a good friend of mine who's now retired. He got his first professorship in hematology at Baragwanath.
How did you then end up at UJ?
I moved into private practice. In other words, I went to work for a company called Lancet.
Lancet Laboratories, yes, I know them, yeah.
I moved from the private sector and then teaching part-time into teaching full-time.
You're still in the field today, so what still excites you about science?
I think the young people today, I met so many young people I was so blessed to go to that Congress, including yourself. I met so many young people that are very enthusiastic. Not all of them, I might say, but the majority actually. And it keeps my passion going, because obviously my profession means a lot to me, as you can tell, I think.
Yes.
My profession means a tremendous amount to me. I've been in it for a long, long time. And the people that I've met throughout the ages, I can put it that way, have been remarkable people as I went through this journey. It is a journey, and I'm still on it in a way, even though I'm kind of elderly, and I don't, I'm not really involved anymore.
Yeah, you quite accomplished yourself. You've written more than 80 articles.
I'm trying to encourage young people to write, and I did that at the Congress. All these people presented the research, and I said, no, you need to write this.
That's definitely important. And you're still writing today. I believe you're working on something now.
If you do not encourage people or inspire them, then you're not doing your job, I don't think, are you? I don't know. I think, that's the problem we have in the world. If we all work, a lab, I'll just mention one thing. A lab is not one person. A laboratory is a team of people. I mean, I'll give you an example. These 2 scientists won the Nobel Prize. They were both Australian scientists that came and found this organism in the gut. Now, you must remember that our gut has got a pH of 2. 2. The scientific world claim, no, there can't be an organism that can live in the gut.
Yeah, an acidic environment, yes.
So guess what the guy did? He infected himself with the bug.
Oh, no.
But then he took the antibiotics and got rid of it.
Oh, wow.
I'm not advising scientists to do that.
No.
But he did it because he knew he could get rid of it. He knew that he wasn't going to develop ulcers. He knew that he could get rid of it. But now that's what they do. They test people for it. And if you've got it, they just give you the antibiotics. Ulceration of the gut is almost unheard of today.
On that note, do you have any message that you would want to leave for young scientists and young professionals listening today?
So I would say to them, you've got to be passionate. You've got to work hard, and you've got to become part of the society, whether you like it or not.
And you need to remember, you might be working with samples, but you're working with people's samples. There's a person behind that sample.
I think there's nothing to compare with it. You know, if you take transfusion science, for example, you can either kill someone or save someone's life by just cross-matching the correct unit of blood for someone. Not miss cross-matching. So the patient's life is in your hands.
It's important. It's important work.
You can't get any more important than that. But also publish. Try and write a little bit.
Previously mentioned people should publish, but you're also publishing something at the moment. Can you just tell me exactly what that is? You mentioned alcoholism or something?
The influence of alcohol on the hematological parameters in patients. Now, hematological parameters, not much has been written about them, and it does affect them badly. Mainly the red cell, the white cell, and the platelets. So really that's what I've concentrated on in this review. And because South Africa has got an alcohol problem, especially among young people, called binge drinking. I've done it from that point of view of saying that we should really incorporate, when we get young people in for testing for hematological problems, then we should look at their alcohol consumption. Because if they've got a macrocytic anemia, for example, which is very common in people who chronically use alcohol, chronic alcohol consumption, the red cells enlarge, they get bigger.
Okay.
Right? So if we've got that in the peripheral blood, then we should follow up on their alcohol consumption. That's what I'm saying. So it's both really looking at the hematological problems and their history, really.
Where can we find your work?
A lot of it is in our local journal, because I decided, right, I'm going to support the journal because I became the editor of the journal, believe it or not.
Oh, fantastic.
And so I was the editor for almost 3 years, actually, of the journal.
And this article that you're writing now, where will that be published? Will you let me know?
I will. I've sent it to our local journal, so I'm waiting on peer review now. Peer review is a huge thing because to get people to, because they have to do it without compensation, you know, and they have to do it in their own time, and they're busy, and some of them are very busy. And so you've got to give them, you got to give them time. That's what I'm saying. But I'll leave you with one story about biomedical science. This is a story about a young man in America, not unfortunately in South Africa, but this young person was diagnosed with a very drastic form of leukemia called acute promyelocytic leukemia. The nice thing nowadays is we've got specific treatments for it, right? So we can get the patient into remission. And this guy did eventually go into remission, and he's been in remission for a long time, which is really amazing. And he was diagnosed when he was 18, I think. 18 years old with this disorder, which is very young for this disease. So it's very aggressive as well.
Leukemia is a cancer in the blood, correct? That causes anemia.
Yes. And this is a type of cell that is associated with problems of causing coagulation problems in patients as well. I won't go into detail, but it causes a disorder called DIC, disseminated intravascular coagulopathies. All right? Big words. But anyway, this guy was diagnosed with this, young guy. He decided that he wasn't going to see the clinician when he got well, right? So there's a video of him. I don't know if you can still get it online, but there's a video of him not visiting the doctors, not visiting the pathologists, but visiting the biomedical scientists who found this disorder in his blood.
Wow.
So he went and spoke to all of them personally. So it's very heartrending, right? He went and spoke to all these people, young, not so young, really quite intelligent, amazing people. And that's what I'll leave you with. But thank you. I'll be in touch.
Thank you so much.